Thank you very much for that kind introduction. I will be speaking today on a publication that probably most of you are familiar with, published in January of 2016, and a result of a several-year effort to really update our global guidance, or background information on breastfeeding. So I have no interest to declare. I guess a researcher in public policy in the area of maternal and child nutrition, and a big advocate for breastfeeding. So those are interests, but I don't consider them conflicts of interest. I just wanted to start off with the two overarching messages that we communicated and in our publications. The first is that breastfeeding is a one world issue. I think for so long it was considered something highly relevant in low and middle income countries, less relevant in high income countries because we had clean water and sanitation and access to nutritionally adequate infant formulas was not seen as a big barrier. But certainly the literature in the last 20 years have absolutely debunked that idea, that it's a one world issue, and babies, no matter where they're born and in what circumstances, geographic, economic, all those babies and mothers will benefit from breastfeeding. So that was really our first key message. And our second key message, and this is a quote in the second paper, which I co-authored, is that success in breastfeeding is not the sole responsibility of a woman. The promotion of breastfeeding is a collective societal responsibility. And it really gets at, again, it's not, the mother decides and then she figures out how to do it. But that we are all responsible for creating an enabling environment to her, and that, from maternity protection that we discussed yesterday to openness and its support for breastfeeding in public spaces, legislation when it's required, worksite lactation policies, et cetera. Certainly the health system, that there's a supportive environment within that health system, and we know that it's often not. So really, again, the message taking away that breastfeeding as a personal responsibility, and that we need to support that mother, that it's our responsibility, that she can exercise her choice of how to breastfeed her baby. I don't think we would all disagree with the statement. In all mammalian species, a reproductive cycle comprises both pregnancy and breastfeeding, and in the absence of the latter, none of these species, including man, could have survived. And again, I think this brings out to more and more information that we're learning about the effects of breastfeeding, particularly as they affect the mother, that, in fact, you need the pregnancy, birth, and the lactation cycle to kind of close that reproductive loop. And particularly relevant for the mother, that practice, as we do more and more research and understand better the effects of breastfeeding for the health of the mother. So getting back to one of the key articles of Cesar Richter, who is the first author on the first paper, when he published this, it really, again, highlighted the importance of breastfeeding in low and middle income countries. I mean, this has been cited over and over and over, showing a 14-fold increased mortality for babies who were not breastfed compared to babies who were exclusively breastfed. This work was conducted in Brazil. But we're in a very different world today than in 1987. Mortality is still an issue, but at the same time, we have more and more urbanization, we have more and more globalization, we have more and more mothers educated, and we have more and more mothers with aspirations for their babies that go way beyond surviving. Mothers that want their babies to thrive and to really be able to enter and participate actively and productively in a very modern world that is so different from the world in 1987 and before. So these two papers, the first one is really Breastfeeding the 21st Century, looking at epidemiology, mechanisms, and lifelong effects, really addressing the one world issue. And then the second paper is Why Invest and What Will It Take to Improve Breastfeeding Practices, addresses the idea that this is a collective social responsibility and provides parameters around that in terms of how we can work, and really the argument, why should we invest beyond the health benefits. The first paper showed this map, which is really the first global map that we have of breastfeeding prevalence data. They reanalyzed more than 127 surveys. I think one of the take-home messages is that compared to low and middle income countries, we have very little data for high income countries. It was much more challenging to get that data and then to be able to actually put those numbers to compare them in terms of indicators to what we have for low and middle income countries. So you can tell, let's see if I can get the, oops, no, I didn't want to do that. Is there a pointer? No pointer. Okay, no pointer. I got to use my finger. Okay, I can use my finger. So the dark green, you can tell Africa. That's not terribly surprising. We have very good breastfeeding practices over in Africa. We don't do quite as well in Latin America with some Latin America with some exceptions. In Central America, you have Peru, Ecuador, and Bolivia. They're very high, and we have lower rates of breastfeeding by and large in high-income countries with significant data gaps that we really wanted to call attention to, particularly as it related to data from some of the high-income countries. I think another really interesting aspect that was looked at was a relationship between exclusive breastfeeding and continued breastfeeding. I mean, one would think in the absence of not having more information on the epidemiology that the longer you exclusively breastfeed, the more likely you are to have a longer breastfeeding duration. That's not the case. So you can hear me. Black is Africa? There's a microphone on the... Yeah, okay. So the black, can you hear me? Does that work? No. I think I'll just talk, because you can hear me, right? Oh, I see, okay. Can you hear me now? There it is. Okay, now you can hear me. Now I'm on the tape. The black circle is Africa, for example. And you can see that, durations are long no matter what. And we're looking at continued breastfeeding between here 12 and 15 months of age. So, we have more than 80% of women on average still breastfeeding during that interval. At the same time, it doesn't matter. It's not related to her length of exclusive breastfeeding. It could be, it's as high if she hardly exclusively breastfeeds, or as high as she's got 60%. 60% of the women are exclusively breastfeeding less than 6 months of age. By and large, this relationship doesn't hold between exclusive and continued. This would be an exception, East Asia and the Pacific. But anyway, it really shows that promoting breastfeeding will be somewhat context specific. In terms of in Africa, the focus is on exclusive breastfeeding. Women initiate and they breastfeed for a long period of time. But to really get all the benefits of breastfeeding in these African settings, exclusive breastfeeding is where we really are trying to make more progress with our policies and our programs. The other fact is that breastfeeding is really one of the few positive health behaviors that's more prevalent in low and middle income countries compared to high income countries. In general, when we look at data around health, there's more positive health behavior in these high-income countries for a lot of different reasons. Breastfeeding is the exception. And so if you look here, the dark bar is low income, the sort of less dark green bar is middle income, and then the two yellows are upper middle income and high income. You can see just in general, initiation, ever breastfed, exclusive breastfeeding, down all the different indicators we use for breastfeeding is much higher in the low and middle income countries compared to the higher income countries. So in what we see in terms of overall measurement, that in low and middle income countries, less than 40% of infants under 6 months of age are exclusively breastfed, and about a third of these between 6 and 24 months of age are not breastfed. But when we compare that to high income countries, it's less than the 40% goes down to 20. And that's only 20% of children that are breastfed up to 12 months of age. We're not talking about exclusive breastfeeding, just any breastfeeding. At the same time, as I mentioned earlier, data are extremely limited from high-income countries. And so it's we're drawing conclusions on this with less than robust data. And we also know that in most high-income countries, it's women who are better educated, wealthier, who breastfeed longer. Something we see very differently in low and middle-income countries where the tendency is reversed, though in Latin America, rapidly changing. This shows about the breastfeeding practices over time. So now we're looking at trends. The solid bars are exclusive breastfeeding, and the dotted lines are continued breastfeeding, 12 to 15 months of age. And then the black are the poorest countries or low-income countries. The green are the middle-income countries, and I've got this wrong. Sorry. Actually, it doesn't say here, but on the thing. So I'm right, actually. The black are the low-income countries. The green are the middle-income countries, and then the yellow are the high-income countries. So we're seeing some increase in exclusive breastfeeding between 1995 and 2014 in the high-income countries. It's pretty flat for breastfeeding from 12 to 15 months of age. And then again, for each doubling of GDP per capita, the breastfeeding prevalence at 12% at 12 months decreases by about 10 percentage points. So again, very, very differences. Overall, trend data are not terribly positive. I mean, we would hope after all this time we'd be seeing a lot more increases as a result of a lot of work that's gone into breastfeeding promotion. This slide looks within countries. So within countries, we're looking at women who are in different places on the economic gradient. So the poorest women in a country, are black, and then it goes to the bright yellow, which are the women in the highest income gradient in these same countries. And so again, what you can appreciate is that for continued breastfeeding from 12 to 15 months of age, the women who are poorest, again, tend to have the most continued breastfeeding 12 to 15 months of age in every single country and every single income group. So again, it's a very pro equity intervention in these low and middle income countries. So in terms of the impacts that were reviewed in the series, there were 22 new systematic reviews commissioned. A few health outcomes did not need new systematic reviews because there had been recent publications of very thorough ones, and those were just used. And these systematic reviews are summarized in actually 11 papers in an Acta Pediatrica supplement that was published in December of last year. It's open access, so it's available to anyone who wishes to download it. 10 of these systematic reviews focused on different biological outcomes, including child mortality and different short and long-term health outcomes. It looked at different outcomes also for women. And then one paper looked at specifically at the interventions to improve breastfeeding practices. Again, systematic reviews looking at different policies and programs. So baby-friendly hospital initiative, code of marketing, maternity protection, counseling, etc. And then the Live Save tool, it's a tool that WHO has developed and uses a lot to model how we can better prevent child deaths, was used to look at the effect of breastfeeding on child mortality. So the bottom line, really, in terms of mortality through this review is that improving breastfeeding would save annually about 820,000 lives for children under 5 years of age, and that almost all of this, almost 90% of it, is concentrated among the first 6 months of life. So, the benefit in reducing mortality and the focus really on when infants are most vulnerable to death from mortality. And then again, the reduction being mostly related to infection-related causes of mortality, again, almost 90% related to that. And again, huge effects were found with respect to prevention of morbidity. That we estimated that by improving breastfeeding, we would prevent 54% of all diarrheal episodes and 32% of all respiratory infections. And these were data from low and middle income countries. Again, for certain things, we have more data from high income countries, and for others, we have much more data for low income countries. And that the protection against hospital admissions was even larger. So it overall reduces morbidity, but it also addresses and prevents severe morbidity. So these were all the different health outcomes that were looked at in the paper. Again, results of all these different systematic reviews that I mentioned earlier. On the other side of the slide here, you can just see this is just an example of the type of forest plot that was used when all these systematic reviews were being done. And so again, it was a very extensive and comprehensive process to identify all the literature in multiple languages, sift through all those abstracts, identify those studies that had, the right outcome, to compare it to what we wanted to be evaluating, and then the analysis. So the breastfeeding clearly was protective against acute otitis media, malocclusion, type 2 diabetes, and obesity. These are all child outcomes. We found no effect on blood pressure, serum lipids, and growth, either weight or length. We did not find any data to support that breastfeeding would be protective of asthma, eczema, or food allergies. And we did find that breastfeeding, prolonged breastfeeding did lead to an increased risk of dental caries. I think, again, really importantly, and more attention being paid to the issue of, the long-term, the thriving part of child development, beyond the health outcomes, but the actual developmental outcomes, and long-term, productivity. It really confirmed, I think, data in some previous studies to show that, on average, breastfeeding contributes about 3 IQ points overall, and this is controlling for maternal IQ. And then some recent data, very recent data, showing breastfeeding associated with improved academic performance and increased adult earnings, again, mediated through IQ, schooling, and then on to adult earnings. A big piece of this was related to the benefits of women's health, as I mentioned earlier. As we think about it as a one world issue, and we think about it also in terms of what's going on in high income countries, huge effects on very serious prevalent diseases. So a mother that breastfeeds decreases the risk of developing, for every year a mother breastfeeds, she decreases the risk of developing invasive breast cancer by 6%. Also a large reduction in the risk of ovarian cancer. And we also modeled the actual numbers of deaths that could be prevented. In the case of breast cancer, the current breastfeeding practices prevent almost 20,000 deaths per year from breast cancer, and that by another double that amount, or another 20,000 deaths, could be prevented by improving practices even further. And then it confirms also that the role of breastfeeding in birth spacing, perhaps less of a concern or an issue in high-income countries, but still a very important concern in low and middle-income countries, women's access to modern contraceptive and the ability to space their births. So it kind of gets to the question, okay, are these biologically plausible? Do we really believe the data that something like breastfeeding could have these incredibly profound effects that are often generalizable globally? And so there's, again, a piece of the paper that really looked at the data around components of breast milk and really how they influence the immune system and other biological, physiological systems in the neonate. And it really came down to this concept of a personalized medicine that's very personalized to the baby because it reflects the mother's environment and then the interaction in terms of how it modulates everything in her immune system to the baby, so that again, some of the components of breast milk, the long-chain fatty acids related to infant brain development, how the bacteria from the mother's gut biome, influences in the breast milk to protect the baby and the baby's development of their own microbiome, the immune cells that are primed in the mother's intestine, all the carbohydrates that are in human milk that are not in infant formula that shape the baby's microbiome, and other aspects. I mean, this was a part that to me was most fascinating about the paper. It really gets into nitty-gritty aspects of human milk and lactation that I think many of us that work in the policy arena don't fully appreciate. And so really the conclusion of this piece of it, the paper that was written by Simon Merck, this piece of that paper was human breast milk is thus not only a perfectly adapted nutritional supply for the infant, but probably the most exquisitely specific personalized medicine that he or she will ever likely to receive, given at a time when gene expression is being fine-tuned for life. And I think this is pretty profound because basically it's looking at, at the moment of birth, and all the different epigenetic processes that are happening at that time. And if the infant newborn is not exposed to this, that this would have lifelong implications for the health and development of this newborn. And this just gets at some of how we use science to really influence policy. All the different ways in which this particular study that Cesar published in 2014 were really picked up, where he looked specifically at breastfeeding intelligence and income at 30 years of age among children that were in his prospective birth cohort in Brazil. So we showed, again, that those babies who were breastfed longer had about a year more of schooling they achieved, and the effects on income were phenomenal. They were explained almost about a quarter to a third of all income productivity could be associated back to these gains in education. There's also data from the US, I think it's less well publicized, but also showing the relationship between breastfeeding IQ and labor markets. So it's gotten the most publicity or press in Brazil, but this is not the only studies that have shown these relationships. Getting back, I think, to the second key message, overarching message of the paper, again, trying to bring it back to society and not leaving it at the hands of the mother, that she can decide, then she has to figure out how to do it. But how do we collectively be sure that she's in a situation, she's in an environment where in fact she can exercise her infant feeding decision. And so this was the model that we took to really look at all the different policy aspects that we evaluated in the systematic reviews. So we looked at structural determinants, the cultural environment, the market context, and I'll talk a little bit about the market context next. The settings that are very, very important in terms of breastfeeding support, health services, which we think about a lot, but family and community, which we talked a lot about yesterday, and then the whole maternity protection and workplace support. And then, getting down to the individual, we talked about some of that this morning, the mother and the infant attributes and the mother-infant relationship. So, kind of the whole gamut in terms of determinants. And then in terms of interventions, again, we evaluated what we know from interventions that looked at social mobilization and mass media, legislation, policy, financing, monitoring, and enforcement. counseling support, and lactation management. There's not data on a lot of these. There's a lot more on counseling support than we know about some of the other higher level inputs. But we did look for what we could find in terms of evidence on all these different levels. So we were able to identify over 20,000 papers, but when you screen down in terms of, what were their measurements and did they really, could they really evaluate with their study design what they were saying they were evaluating? We came down to 300 studies. And the bottom line was that breastfeeding practices are highly responsive to interventions. I think we know that from many low and middle income countries where you've seen dramatic increases in a relatively short amount of time. But we've got, examples in Africa, Latin America, I think some Asian countries, just phenomenal increases in a very short amount of time through a series of policy and program mixes that address all the different levels that to provide a supportive environment, i.e. removing all the barriers that women face to breastfeed. So that overall, that the practices are highly responsive to interventions delivered, in the health systems, communities, and homes. Specifically, that health system and community interventions can increase exclusive breastfeeding by almost 2.5 fold. The maternity leave and workplace interventions are also beneficial, but again, we only had data in this case from high-income countries. We really couldn't show this for low-income or middle-income countries. Synergistic effects, the more you do to address these barriers, the bigger the effects you're going to have. And so very important in terms of policy is not to focus on a single policy, but look at different policy levers and how you can really use those to synergistically provide this enabling environment. And then getting back to one of the points I made earlier on related to, is the focus on exclusive breastfeeding or duration or both, depending on the context and what are the prevailing cultural patterns and practices, a different mix of interventions would be needed and context specific. So we are working very hard to protect, promote, and support breastfeeding, and we're up against a big industry. It's just phenomenal how big this industry is. These are data from Euromonitor. It's a busy graph, but I'll try to just get to a few of the bottom lines with respect to it. So this is retail sales in US millions of dollars. We're starting at year 2000 and going up to projections through 2019. This is volume in terms of thousands of tons of formula. And this is growth in percent terms and by year. And so basically you can see that growth on average, this first bottom line, I guess, is around 5% per year, a small market downturn during the economic crisis of 2009. Beyond that, this is, a good place to be investing if this is your cup of tea. It's a growth market, okay? And I think the second major point is that right now, so in 2014, the market was about $45 billion per year. That's last year, a year and a half ago. It's estimated to be at $70 billion by 2019. And this is largely because of growth in middle-income countries. The market for infant formula is saturated in high-income countries. Ironically, there's 2 countries where sales of infant formula are projected to go down between 2014 and 2019. The US, 0.8%. So, not a lot, but it's, 0.8%. We're doing something right in breastfeeding in the US if, in fact, we're actually, they're projecting negative growth in infant formula sales. France is another country where it's projected to go down a little bit, but again, it's interesting. I don't think you would have even seen that another year or two ago. But oh shoot, is that my phone? Sorry. Can you find it? Should have turned it off. At least it's not my dog barking. My old fund had my dog barking on it, and then I'd have to say, excuse me, my dog is calling. So what's going on in the high-income countries is that growth, thank you, Elizabeth, growth in the market is fueled by the follow-on formulas in the growing up milks. So they're really pushing these milks beyond the infant formulas to keep their market growing. And so for those of you who paid attention to the World Health Assembly a few weeks ago, would be interested about the new guidance from WHO that actually specifically address the fact that follow-on formulas in growing up milks are breast milk substitutes and therefore fall under the scope of the code, and that marketing guidance should be up to 36 months of age for a child. This is huge because there's always this debate, when did the code stop? And in general, industry would say, yeah, 6 months. Okay, we'll kind of stay away for 6 months. But now there's guidance that really includes these products specifically, and also addresses the age at which breast milk substitutes should not be marketed or promoted, I should say, promoted. Also, what's going on in middle-income countries is largely, again, being driven primarily by baby formulas, infant formulas, but also pushing the follow-on formulas in the growing up milks. So that, and the biggest market really is in the biggest countries. So China, like number one. I mean, that market is just huge. Thailand is another big country. Vietnam. So we're looking at, again, populations with large populations, but with a lot of economic growth. I mean, the companies are, looking at the trends in economic growth and targeting these specific, particularly these specific countries where the growth is huge, but it's generalizable in terms of efforts to reach these moms and reach them very early on. I have a slide that I didn't include here, but it just shows some of the Abbott promotional material, how their market is growing, and it has, a mother from South Africa, beautifully dressed, beautiful baby, that's the target. While they continue, obviously, to target mothers in high-income countries, they're going after a whole new market, and recognizing that, they're kind of topping out in this country and other high-income countries. I think Elizabeth participated in the writing of this editorial, and is one of several accompanying editorials to the Lancet series. And it just says, again, the most vulnerable suffer when commercial interests collide with public health. Robust advertising regulation covering all milk products for children up to 3 years and banning social media promotion is a next step to promote them. And again, this was followed up. The new guidance from WHO doesn't specifically mention social media, but it talks about promotion, and so that's it. Social media is another way to promote, but specifically addresses other products that are marketed and argued not to be breast milk substitutes prior to this new guidance and the resolution. A lot of effort was put into estimating or making the economic case for breastfeeding. I think those of us who work a lot in policy, a question keeps coming up, but how do we argue beyond the health benefits? How do we get to the ministers of education? How do we get to the ministers of finance? How do we kind of raise this politically above just a health issue? Because certainly in the region I work in, Latin America and the Caribbean, health ministers don't tend to have a lot of power. If you really want to see public policy, you've got to get to some of the more powerful ministries. And so for the first time, an estimate was made on the economic gains for breastfeeding and basically deriving these from the IQ benefit and then translating that into market productivity. And the economist on the team came up with a number of $302 billion per year in terms of the economic gains from breastfeeding, which comes out to about 4.5 percentage point of global gross national income, which is a huge number, just a huge proportion of the over indicator. They also looked at the estimated health benefits in terms of reduced health costs. We could only do this for the US, UK, Brazil, and urban China just because of data limitations. But again, the estimate was about 400 million in terms of health care cost savings. So just getting down to then sort of the bottom line in terms of how do we build this enabling environment? Because ultimately, from a policy perspective, that's what we need to do to really provide moms the ability to carry out their choice to breastfeed. And so, again, we identify the package of policy options and programs. But overall, we felt that the biggest areas we had to work in are to disseminate accurate information on the value of breastfeeding. Again, a one world issue, important for health, both the mother and the baby, the cognitive development aspects, educational aspects, aspects in terms of productivity later in life, to foster positive social attitudes towards breastfeeding. Again, not something for low-income women, something for all women, and to, again, getting back to the conversations we were having yesterday, looking at breasts as, for breastfeeding and not just as sexual objects, to really work on demonstrating political will to support breastfeeding. I mean, World Breastfeeding Week every year, all the ministers of health in my region say, yes, and we're going to promote breastfeeding, but so where's the budget? What specifically are your goals for monitoring the code? Are you looking at maternity protection? I mean, really trying to hold policymakers accountable and not just giving lip service once a year to support breastfeeding. Getting back to the data I was showing on the global market for breast milk substitutes, a clear message to regulate breast milk substitute industry by strengthening the code. And I think now, again, with the recent WHA guidance and resolution, we have much stronger language that we could be putting into these, into new legislation. I was just in touch with Colombia yesterday. They're updating their legislation, and right away I was like, okay, we have these new WHA resolutions that we can use again to support how we're strengthening legislation. This is one country, but I think we can use this globally. WHO, UNICEF also have a new international network for code monitoring and implementation, and so have been working with a number of other NGOs, including IFBAN and also HKI and a number of others, to develop a global protocol. We're pilot testing it in a number of countries globally right now. Mexico has completed theirs. Chile is about to start. But again, looking at how we can globally do a better job using very scientific protocols to measure what's going on with respect to promotion of breast milk substitutes. But another big piece of this global initiative is how do we get ongoing monitoring systems in place so you don't depend on a survey every 5 years. But in fact, there's a way for countries that have codes where a nurse, a doctor, a mother, grandmother, whoever can go to the web, upload a violation and have a way to have it investigated, and if appropriate, the appropriate measures taken. So again, another huge effort that WHO is leading with support of UNICEF and a number of very, very active NGOs trying to broaden the base of support for work related to the code. Clearly, we want to scale up and monitor breastfeeding interventions. We want to scale them up, but we also, the more evidence we can show that this works, this is what it costs, this is how we can do it better, I think the more evidence we have, again, to argue for increased investments in breastfeeding. And then lastly, to really, again, focus on the maternity protection, the benefits with respect to how long a woman has maternity leave, but also to be sure that there are workplace provisions in terms of time to express breast milk, safe places, to store it, private spaces, et cetera. So those were our key messages. We have a lot of opportunities, I think, to really scale up what we're doing. We have a lot of new human rights instruments that are being increasingly used in many, many countries throughout the world. We have the 25th anniversary of Baby Friendly coming up. WHO will be doing a global congress with UNICEF in the fall. So again, many opportunities to try to highlight breastfeeding as a one world issue and a collective social responsibility. So again, just a few examples of some of the controversy that gets generated around breastfeeding, all the discussions that happen over this, the pros and the cons. But again, looking at how we can support women if they're asked not to breastfeed for some reason, or really making the whole world a more hospitable place to the breastfeeding woman. And then in closing, one of the other editorials that was written for the series was by a vice president from the World Bank and a big breastfeeding champion. Breastfeeding did not already exist. Someone who invented it today would deserve a dual Nobel Prize in medicine and economics. And I think that's the last one. We were funded by the Bill and Melinda Gates Foundation, and then a long series of the writing team, and then many others that provided the systematic reviews and other analyses related to the trend data on breastfeeding. Thank you. Yeah.
We all want to put it on a t-shirt.
Oh, that's a good idea. Anyway, thank you.
So, we have questions? We've got probably 6 minutes or so before it's noon and we're supposed to eat, but so we're stretching a little bit. We'll have to quit.
Thank you, Dr. Lutter. That was an excellent review. I have a question that's fairly narrow, but it has to do with science and policy, and as a policymaker, your thoughts about it. And you mentioned that breastfeeding you didn't have evidence to prevent asthma or eczema. And as I'm in the trenches, from the University of San Diego, California, Isla Boys, I find myself sometimes at odds with the recommendation to exclusively breastfeed for 6 months. And that's one of our benchmarks that we track. And specifically when I go to other meetings or my residents or students say, but the allergists say we need to start introducing other foods at 4 months to prevent allergy. I try and counter that by saying, well, breast milk, they're getting exposed to other proteins and antigens without a lot of data, I admit. But again, it's one of the benchmarks we use, and there are competing forces, I think, in the science that translates somewhat to policy and benchmarks we're following, and I just would like your thoughts on that.
Yeah, thank you for the question. With respect to the early introduction, so I know that's a hot issue right now. I'm very aware of the fact that that's a very, very hot issue. My read is that, we have one key article that's showing that's been picked up by some other...
You referred to the peanuts?
Yeah,
In
I'm referring to
Israel.
that. I'm referring to that. And that has
Yeah,
been,
the Bomba
picked
effect.
up widely in the media. It's been also, brought into other articles, the British Medical Journal, but really picking up on that one key article. So 640 kids were randomized between 4 and 11 months of age to the intervention, which means we have, 160 kids in the 4 to 5 month old range. I haven't looked at the paper recently, and I couldn't tell you if, did they sub-analyze for those 160 kids between 4 and 6 months of age? I don't know, maybe if they did, then, that's a really important finding that needs to be taken very seriously. If they didn't, and you don't have the power to really say something for that age range, then, I think, again, we would like more research no matter what. I mean, one paper should not be driving policy. I think the other issue there to consider is that, again, the intervention was 2 grams of peanuts 3 times a week? So
I don't know the
no,
specifics.
yeah, that's what I recall. Okay, so if again, if this is confirmed that this is something very relevant between the 4 and 6 month period, how you frame that in terms of a recommendation, I think that is really important. So, for example, when WHO recommended 6 months as a global recommendation for exclusive breastfeeding, you really have to look at how the nuances of that, or how that is teased apart for different settings. It says very clearly that decisions about when to introduce complementary food should be based on an individual child's growth, and all these other parameters. It's not saying every child, every clinician, every. It's saying globally, this is a recommendation. We have global recommendations for a lot of things, or a national recommendation. Doesn't mean you don't pay attention to the specific clinical aspects that would cause you to, do something differently. I think that's very clear in the WHO guidance for 6 months of exclusive breastfeeding. It's not saying every child, every time, in any circumstance. It's just saying globally, this is what the data show are best. So back to the peanuts. Again, I would like to see more data on this. I would like to see if they took those 640 kids and really teased out those 160 that were in the 4 months, 5 months old range, see what happened there. But let's just say, we've replicated the study. We absolutely can show that between 4 and 6 months, kids are better off if they get this challenge. I think it's then, how do you frame this? Do you go back to exclusive breastfeeding 4 to 6 months? That, I don't think, is really framing what the issue is. I think the issue is exclusive breastfeeding, and for kids with this allergy risk, whatever you decide is the appropriate dose, 2 grams, 3 peanuts per week. I think you can tailor it in a way that addresses an important clinical consideration, an important health consideration, at the same time not throwing the baby out with the bathwater at all. So
I agree with you.
Okay.
I just think, again, it's an issue that's out there, and that
For sure.
I think we need to face and look at
absolutely.
as breastfeeding proponents.
Yeah, absolutely. Yeah, absolutely.
Short. Otherwise, you're not going to get to eat.
We'll skip lunch. There may be peanuts there. I just want to, I was a bit confused by the summary slide, which tells, you say that the only evidence, not you, but it was summarized that the only evidence in terms of effect on infectious disease is otitis media. That doesn't make sense when 3 slides before that you showed me that significant reduction of gastroenteritis, respiratory disease, hospitalization. Why wasn't that expressed in the summary slide? Because if the only benefit is otitis media, that's a hard, in terms of infection, that's a hard sell.
Well, it's clearly in the systematic review because it was presented in the presentation. So I think it's not in the summary slide because we had already presented the data on it. Expand the summary slide. It's already a pretty full slide. But yeah, we could add a few more.
Wait, I'm confused. You show a slide that the only benefit in terms of infectious disease is reduction is otitis media. That means the other ones you already mentioned, or why didn't that appear on a slide? It's a very strange slide to show.
Well, it's
because you also said it doesn't benefit against preventing
No.
allergy and asthma. It makes one wonder about what data set used to come to those conclusions. If you did include gastroenteritis and respiratory disease.
We clearly did, and I showed that data earlier.
But what is that summary slide then?
The summary slide is adding to the things that were shown. I mean, I can't go into detail about every single outcome the way I did for mortality, diarrhea, and
Okay.
respiratory infections.
I
So
would like-
we wrap it up with a slide. And that's, it clearly doesn't indicate that those aren't important. It just indicates, in addition, these are other benefits. So-
Okay. You should then revise the slide because it doesn't say that. It doesn't say in addition.
Hi, Casey Rose and Carol Rochester. I'll be fast. My comment is about language because I think there are lots of inspiring quotes about how great breastfeeding is in the systematic reviews. And if we're quoting a former ABM summit when David Myers said that the jury is no longer out, right? Breastfeeding is superior. So what I'm thinking about, and one of the things that I always end up at the end of conferences about is this thought about that we're still using the breast is best language everywhere. And as long as we frame studies that way, we have to frame systematic reviews that way. And so my call out is to various editors and regulatory agencies, as long as we devise these studies as trying to figure out what the benefits of breastfeeding are, then we're still in the breast is best, which means that we're positing an equivalence and we're positing that the breast is the alternative. Whereas infant formula, it is largely argued, is the largest unresearched experiment in infant health that we've ever seen, which means where is the burden of proof? And I think that where this field needs to go is we need to shift the burden of proof from a regulatory standpoint to the breast milk substitute industry and say, look, if you want to do what you are doing, you have to prove that it is safe, because we already know, you know, and whatever the systematic review finds about this one disease or that one disease, we know this is baseline. We have to change the way we pitch this. And it's not a critique on the Lancet, because you can only do a systematic review based on what the data are giving you, right? So I just was wondering if you could comment on that, because also a lot of the quotes feed that, right? That, you know, breastfeeding, you know, if it didn't exist, it's the best intervention, it's the best preventive. It's not an intervention, right? Infant formula is the intervention. So it's just...
No,
Right, and it's tough because you're dealing with the data that are already that way, right? You can't change that.
Yeah, I know. We debate. I mean, there's obviously a lot of debate. I absolutely, totally agree with. We don't want to use breast is best. Absolutely. I mean, we've got to move beyond that catchphrase. Right. I think what we're also trying to do with this is move into, you know, other issues beyond health, to look at economic productivity, you know, to look at the other aspects beyond the health. Right. And I think whenever you do something, it's, do you put it in the negative and the positive? And this is debated endlessly. And I don't think there's a single answer. I think it's probably very context specific. I think it maybe depends who you're pitching it to. But I agree. I think how we frame it is ultimately, I think, going to make the difference in terms of, you know, the effects that we get in terms of different policy changes. But I don't think there's a single answer, but I absolutely agree with you that we need to think really hard about it, you know, so we're really articulating all the aspects of breastfeeding in a way that are going to, you know, get more support in the bottom line for mothers. So.
Thank you so much.